Right, so my name is Mark Driscoll. I am the program manager for the Preventive Health Program with the Ohio AAP. And we also have the medical lead for that program as well, Dr. Chris Bowling, with us today. I have just a few things to state before we begin, and then I'll introduce our speakers. Today, we are proud to partner with the Ohio Department of Health, but as you see, the disclaimer here shows that the views and opinions in this presentation do not necessarily represent the policy or position of the Department of Health. If you have questions throughout the presentation, please feel free to use the chat box to put those into the chat box, and we'll either answer them throughout the presentation or we have time saved at the end for questions as well. Just make sure that you stay muted so that the speakers are able to easily move through their presentation. And then as a closing note, if I don't get time to say this at the end, after today's presentation, I will be sending an email with instructions on how to claim CME and MOC Part 2 credit. So that will come either the end of today or tomorrow. Then without further ado, I'll go ahead and introduce our speaker and her team. Dr. Anna Mitchell is a board certified in pediatrics and medical genetics and currently practices at University Hospitals in Cleveland. She is the medical director at the Center for Human Genetics at UH and also is program director for the Medical Genetics Residency Program. Brandon Hoff and Rachel Van Coyley are residents in the combined Pediatrics Medical Genetics Residency Program at UH. And thank you for being here today.
Thank you for the introduction. I am Anna Mitchell, as Mark said, and thank you for joining us today. We wanted to go over some information about Duchenne muscular dystrophy and the newborn screening process that we hope will be helpful to you in your practice. And so just we have the AAP statement here on DEI. And then we don't have any disclosures. And here are our learning objectives for the talk today. And so just I thought we'd get started by going over some background information about Duchenne. And so it is the most common childhood onset muscular dystrophy. So it is something that you could run into in your practice. It's actually, Duchenne is part of a spectrum of disorders that are referred to as the dystrophinopathies. And they result from mutations or alterations in a gene called DMD. And that gene makes a protein called dystrophin. And the dystrophin protein is, it says there, it's part of a complex that helps link the interior cytoskeleton of the cell with the external environment. And so dystrophin serves as it's a protector of the muscle cell, helping it recover from injury, withstand the forces that a muscle undergoes on a daily basis. And if a cell doesn't have enough dystrophin, that muscle cell can get damaged and eventually die. And so that is what leads to the symptoms that you see in Duchenne muscular dystrophy. It results from the muscle cells not having enough dystrophin. It is expressed in skeletal muscles, cardiac muscle, and smooth muscle, so all the different muscle types in the body. And so those are going to be the organ systems where you will see symptoms in patients who have Duchenne. The DMD gene is on the X chromosome. So just as a reminder, females have 2 X chromosomes and males have an X and a Y. And so that means that Duchenne is much more likely to show up in boys and males than it is in girls or females. Females having that extra X chromosome, that's kind of protective. So if they have 1 X chromosome with a mutation in the DMD gene, they do have a second copy that can help compensate for that. There are women who do have symptoms, but by and large, it's much more likely to show up in boys and males. In terms of frequency, some thought that somewhere between 1 in 3,000 to 1 in 4,000 live-born males will have Duchenne. And so from our standpoint in the world of genetics, that's relatively common for a frequency of a condition. So again, something that will be seen in pediatric practices and genetic practices. And so going back up to that top there with the different spectrum of the dystrophinopathy. So you see Duchenne is over on the left. So it's the most severe presentation, and people who have Duchenne make very little to no dystrophin protein at all. So their muscle cells are very easily injured and damaged. So that's the most severe features. Going to that next one over, Becker muscular dystrophy is very similar to Duchenne in terms of the features present, but it's milder. And so people with Becker muscular dystrophy make some dystrophin. They don't make as much as normal, but they make enough that it leads to them developing symptoms at a later age and having a milder presentation. And so that is just something important to remember when we get towards the end of the talk and are talking about therapeutic options, that Becker is very much like Duchenne, except it's milder. Then right in the middle, you have DMD-related cardiomyopathies. So there are some mutations or alterations in the DMD gene that lead to a person only having symptoms in the heart. So they don't have skeletal muscle findings, but they'll have cardiomyopathy. And then as you go more towards the right of the spectrum, you'll notice these are the milder versions of dystrophinopathy conditions. So you might have a person whose only symptoms are to have muscle cramps, and then noting some myoglobinuria with exercise or exertion. And then the most mildest form of DMD mutations are going to be folks who have no clinical symptoms, but if you were to draw a blood sample, you might find they have an elevated CK. So maybe some mild muscle damage, but nothing that's leading to symptoms. And again, all of these are on a spectrum. They all result from having alterations in that same DMD gene. So just going on to some of the clinical features for Duchenne. So muscle weakness is the most prominent. Again, going to be typically proximal in terms of location on the body. One of the most common things that's seen is delayed in gross motor milestones, particularly walking. So these kids do learn to walk, but it's going to be on average later than their typically peers. So about 18 months or so. They will have trouble getting to a standing position. So this figure here shows the Gower maneuver, which is something that's commonly mentioned in the context of Duchenne. And so due to that muscle weakness, a child's unable to just go from a sitting to standing position, but ends up having to sort of use their hands to walk themselves up their legs to get in an upright position. They can have a waddling or atypical gait. They can have trouble with climbing, running, jumping. You also might note prominence of the calves, something called pseudohypertrophy. It can look like you've got well development of the calf muscles, but actually what you're seeing is the muscles being replaced by fibrous fatty tissue. So you'll notice this prominence to the calves in these kids. And then there are some neurodevelopmental things that can be associated with ADHD or autism spectrum disorder or some learning disabilities. These tend to be non-progressive. It's not a neurodegenerative kind of condition, just kind of some baseline differences in neurocognitive skills. I think it's important to note that these symptoms start showing up in toddlers, and average age of being diagnosed is typically between ages of 3 and 5. Newborns do not, with Duchenne, they do not have symptoms. You're not going to notice anything in the newborn period in a baby who has Duchenne. It's really a toddler onset condition. It is progressive, and so there is ongoing weakness. So as I said, kids typically learn to walk, but they do become, as the weakness progresses, wheelchair bound, often in late childhood to early teenage years. As they get older into the later teen years, they will develop the cardiomyopathy symptoms. And then the respiratory insufficiency becomes more of a problem, the very late teen years or even early 20s. And individuals some of them do go on to get trachs and ventilators that will prolong the lifespan by 5-ish years or so. But on average, children with Duchenne's typically have a lifespan historically was in the 20s. And now there are some treatments that are being developed, we'll talk about later, that is extending that. But typically prior to these therapies, average lifespan was 24 to 25 for folks who didn't get trachs and vents, and then 29 to 30 for children who had the ventilators. And that's kind of it for the clinical features of Duchenne. Next, we thought we'd talk about the newborn screening program that's been put in place in Ohio to screen for Duchenne. And I'll let Brandon will take over here.
So I think this was started on the Ohio newborn screen in April of last year. Now it is 2025. And I'm sure many of you probably have had more than several inconclusive results that have come back to your clinic. And we want to provide some information about what to do with those results and provide reassurance if you've already been following up on them. So it uses the same dry blood spot as every other analyte on the newborn screen. There's nothing additional that's done in the nursery. When it gets to the lab, what they measure is the fractionated CK-MM levels specifically. As Dr. Mitchell previously mentioned, Duchenne is an X-linked condition, so males will typically have much higher CK-MM levels than females. That can be related to the size of the infant, but it's more so related to the fact that it's an X-linked condition. These are the cutoffs that are published by the Ohio Department of Health. These are for infants who are over 2 kilograms. If you're under 2 kilograms, then your result will always be inconclusive. And I'll demonstrate that with a flow chart on the next slide. These cutoffs have been validated in the lab, and they are certainly things that may change in the future, but these are not things that you'll typically see on the newborn screen report that is faxed to your office. These are just kind of for your information, so you know what the lab is using to develop these cutoff markers. You probably haven't gotten an elevated results. I don't think any of us have here at university hospitals. The only way to do that is if it's collected after 168 hours, which is 7 days of age. Most of the hospitals will collect it right around 24 hours or shortly after. Here's a flow chart to help you identify what your best next step should be when you get results from the Ohio Department of Health, whether it's inconclusive or elevated, and depending on the infant's weight. So typically the newborn screen will be collected after 24 hours of life, and it will be sent to the lab. In the report that you're sent back, it will typically be either within range or inconclusive. And as I mentioned, rarely it could be elevated if it's collected after 7 days. If it's inconclusive or elevated, your action item is the same. You will repeat the newborn screen, or you will order a total CK level when the infant is both 2 weeks old and greater than 2 kilograms. I want to point out here that the follow-up action is equivalent. It could be either a newborn screen or a total CK. There's not one that's preferred over the other. And I also want to point out that it's a total CK that you're ordering as a follow-up item and not a fractionated CK-MM like the newborn screen lab is doing. If any of you are familiar with the American College of Medical Genetics ACT sheets that provide flowcharts for pediatricians and primary care providers about how to follow up on abnormal newborn screen results, they do have a published algorithm for Duchenne and elevated CK levels. And it does mention ordering a CK-MM fractionated as a follow-up action. But since Ohio is the first state that's been doing this, we think it's best to follow what the ODH is recommending that we do, and that we're all consistent in ordering a total CK. As more states add this to their newborn screen, we may have a better understanding of what analyte may be better, but in general, the total CK is much more available and much more affordable. Most hospitals may have to send out a fractionated CK, so it adds to the turnaround time and adds to the cost. Once you order the repeat newborn screen or the total CK to follow up on the results after the infant is both greater than 2 weeks old and greater than 2 kilograms, if it's within range, you can feel safe that it is a false positive and there's no additional follow-up that you need to do with it. If it's elevated, then that kind of ends the road for the pediatrician, and that's the time to refer to a Duchenne muscular dystrophy specialist, whether that's a geneticist in your region or a neurologist, either one, whichever you feel would be better served for your patient. As many of you probably know, CK is not at all specific for Duchenne. In fact, it can be indicative of a lot of different things. So the birthing process can contribute to elevations in CK. And I don't want you to get bogged down on the CK level for a vaginal versus cesarean delivery. It's more so related to stressing factors during delivery, like the duration of labor, whether there was shoulder dystocia, whether there was any, if the infant was breeching, required any maneuvers to reposition them, if it was an operative delivery requiring forceps. Those are all things that can elevate the CK. Gestational age, independent of infant weight, can also elevate the CK. Bigger infants can have higher CKs, but also older infants, so further along gestational age, independent of weight, will have a higher CK level than a premature infant. Other types of muscular dystrophy, and we don't put this on the slide, but other things that are looked at on the newborn screen can also elevate CK. Sometimes SMA can, sometimes fatty acid oxidation disorders can elevate your CK level. So if this last bullet point is probably the most important. As Dr. Mitchell previously mentioned, infants or newborns with Duchenne do not have symptoms. And if you have an infant who is showing any abnormal neurologic signs, then you should consider other etiologies for this and refer them to care, and not rely on the CK as being specific at all for Duchenne. So now we want to switch gears a little bit and talk about why Duchenne was added to the Ohio's newborn screen, and what kind of treatments might be available for this.
Yeah, perfect. So now that we have talked about the logistics, yes, we wanted to touch base on why it was added in the first place. And this actually goes back to principles outlined by Wilson and Youngner back in 1968, back when newborn screening was really in its infancy. And these principles were created to help guide the choice of what conditions should be screened for in large populations. And these principles and or derivatives of them are still help us decide what is going to be on the newborn screen now. And we're not going to go into really most of these criteria, but we just wanted to highlight the second one here, is that there should be an accepted treatment for patients with a recognized disease. So there has been a lot of improvement and development in treatment for DMD over the past 30 years, and even more so over the past 10 years. So now that we have some more treatments for DMD and we continue to make progress in treatments for DMD, the goal of adding this to the newborn screen is to be able to identify patients with DMD early so that they can receive those treatments earlier and at the most optimal time. Additionally, if we are able to identify an infant with DMD on the newborn screen, this then lets us figure out if there's other older siblings or other maternal relatives who could be at risk as well, so that they can be monitored and enrolled in treatments as needed. So what are the treatments for DMD? So as pediatricians, as I'm assuming many of you are, you're probably not going to be involved in prescribing a lot of these medications, but we thought it would be helpful to at least give some examples of the treatments that patients with DMD get, so you have a little bit of context. So classically, treatments for DMD were primarily to alleviate symptoms. So for example, in patients who have cardiomyopathy, they might be treated with medications such as ACE inhibitors, beta blockers, diuretics, and supplemental oxygen as needed. Those people with the DMD-associated cardiomyopathy, but without other skeletal involvement, might have actually even undergone cardiac transplantation to help too. And then, of course, as Dr. Mitchell mentioned earlier, respiratory assistance, such as ventilation, for people with respiratory failure. And then patients with scoliosis can be treated with bracing and surgery, as like any other patient with scoliosis. Of course, physical therapy is super important for these patients to help, maintain their strength and function for as long as possible. And then calcium and vitamin D can be used to help maintain their bone strength. And then corticosteroids actually are now recommended for all patients with DMD over the age of 4, as clinical trials have shown that they have delayed some disease progression and they can lead to increased muscle function and strength. And this is because, though it's not the primary process of how DMD works, as Dr. Mitchell mentioned earlier, there is some thought that there's a bit of an immune/inflammatory component to the pathology of DMD. So that's why trials with those started. And they actually are now the standard of care for patients with DMD. But as we all know, long-term daily use of steroids is associated with some pretty significant side effects. And so the previous therapies that we had for patients with DMD were largely symptomatic, but recently there have been some more developments in therapies aimed at addressing the root cause of DMD. So trying to restore the dystrophin protein. And the ones that are currently available to us can be broken down into either exon skipping medications and gene therapies. So we're gonna just keep this kind of higher level about what exon skipping ASO therapy is. Just to review a little bit of genetics, what we mean by exon is just the protein coding parts of our genes. And so when someone has DMD, they have a mutation in one of these exons. And when they have that mutation, it leads to the protein making machinery stops early. And essentially you have either a little bit of dystrophin produced or none at all. And so that gives someone the symptoms of DMD. So what exon skipping ASOs do is essentially they kind of cut out that exon from when the DNA is going into protein. So this actually allows the body to create dystrophin protein, but there's kind of a little chunk in the middle missing. And so you have a little bit of a shorter protein, but it is functional. And this actually creates more of a Becker muscular dystrophy phenotype. So that's what Dr. Mitchell had mentioned earlier. There's different spectrums of the dystrophinopathies based off of what the dystrophin looks like. So this therapy isn't what I would say a quote unquote cure for DMD, but rather it changes people from having that more severe Duchenne clinical picture into a milder, more Becker muscular dystrophy clinical picture. And you definitely do not need to know most of what's on the slide, but this is just to give you some examples that there are multiple different FDA-approved exon skipping ASO therapies available for people with variants in different exons. As you can see, they are then specific to people who have mutations in those exons. But the goal of the medications that were created is that they are supposed to be targeted towards exons that are what we call hotspots. So they're areas where a lot of people with DMD have mutations. So the goal is to be able to help a larger percentage of people with DMD. And the other option that we have currently available to us here in the US is Elevidys, which is a gene therapy. And actually, so gene therapy is really interesting. Essentially, what you do is you have to use some sort of vector. Most of the time, this is a virus, to be able to deliver a functional gene to the affected tissues. So with DMD therapy, we use what's called an adeno-associated virus, or an AAV, because it naturally affects skeletal muscle tissues and cardiac muscle, which, as we talked about before, are the tissues that are most affected with DMD. So that's why AAV was chosen. The tricky part about AAV is that it's really small. It's pretty small. And dystrophin, on the other hand, is a really big gene. It's actually one of the largest genes we have. So the whole gene itself doesn't actually fit into the AAV virus. And so what scientists have done to try and get around this is they have created what's called microdystrophin, where basically they only include the parts of the gene that are absolutely necessary for creating a functional protein. And they designed this to mimic somebody who had a very mild form of Becker muscular dystrophy. So once again, though they are delivering a gene to the patient. With DMD, with this therapy, it's a microdystrophin gene. It's not the full thing. So it is more so converting somebody from a Duchenne picture to a Becker picture, as opposed to technically curing the disorder. And this is just for reference, in case people are not as familiar with gene therapy. It can be done in a couple of different ways. So ex vivo versus in vivo. Elevidys, so the therapy we just talked about, is an example of an in vivo therapy where it's just directly delivered to the patient via IV. And this is opposed to ex vivo gene therapy, where somebody undergoes stem cell extraction, the gene therapy is then applied to those cells outside of the body, and then those cells are introduced back into the body. And that's, so for example, if any of you are familiar with the sickle cell gene therapy, that's more so how that one works. And so those previous ones are the ones that are available to us now in the US. But there are a lot of therapies in development. There's always people working on more therapies. And I'll get into them a little bit more in the next slide. So the first one I want to mention here is called Adalurin. It is similar to the exon skipping medications, but a little bit different. So again, in DMD, you have a mutation that's telling this protein making machinery to stop early. This medication essentially just tells it to read right on through that stop signal and keep making the protein. Which is really, really cool. It is currently only approved in Europe, and it had previously been denied by the FDA. At the time they had applied for approval, there wasn't enough evidence that it was actually clinically helpful. But I was just looking, and there have been some more clinical trials regarding this medication that have shown improvements in patients with DMD. So as of November 2024, the FDA has allowed them to apply again for approval. So this may become available to us soon. And then some other therapies in the works are gene editing using the CRISPR-Cas system. And this is just a picture here, a simple one to overview, where you basically can find the mutation in the DMD gene, you can cut it out, and then you replace it with normal DNA to help restore that gene and subsequently the dystrophin protein. But still have a lot of work to do in regards to this therapy. So a lot of different options out there. Really, the overview I wanted you guys to take away from this part of the presentation is that, you know, the goal of putting DMD on the newborn screen is to help identify them so they can get some of these treatments earlier. But it's important to keep in mind that when we're setting expectations for our patients, that a lot of these therapies don't necessarily cure it, but they turn it into a milder disease. They can be specific to certain people with certain mutations. And so I think that's all just important to keep in mind.
And then one of the things that we just wanted to point out is as the genetic centers in the state of Ohio, that we are here to assist in any way that we can. And so we welcome phone calls asking about logistics of how to do something or what should be done, or just specific questions related to specific patients or general questions. We want to be a resource to you as primary pediatricians out in the communities who are receiving these results. If you need help clarifying them or what to do with inconclusives, we want to be helpful with that. You know, the cutoffs that Brandon talked about with the current use on the newborn screen, ODH is always evaluating the use of cutoffs, refining them as more testing is done. We want to try to minimize the number of false positives that we're getting on these tests. So that is kind of work in progress, making the test better, but we definitely want to be here as a resource and want you to feel welcome to reach out to us if you have any questions. This is just a map of the state of Ohio showing there are 8 genetic centers in the state. And here's where they're located. There's contact information here for them, but we just wanted to make sure everyone is aware of these resources and that we are available and want to be helpful. So please reach out to us. And then there's the link there that shows the electronic link to all of these, the contact information for these centers. And then here's just some resources and references. And just one more thing that I had wanted to point out that I forgot to mention is that we talked about the genetics and inheritance of DMD and being excellent in that, but wanted to point out that a significant proportion of patients with DMD are going to be the first ones in their family to have it. About a third of boys who present will be new mutations or the first one in the family. So you will not have any family history to go on to even suspect this for the patient. And so it's a little bit different from other conditions where typically there is a family history and you might have some warning this is going to happen. About a third of Duchenne boys are going to be the first ones in their family. So just remembering that means that you aren't going to get any kind of family history when you're talking to parents about the condition. And then we can take any questions at this point. That was all information that we had prepared.
Thank you. I'll just jump in real quick to mention again, if you would like, you can enter questions in the chat box, or you feel free to unmute yourself and ask the questions. Just from my end, real quick before people, if you're logging off, I do want to mention that we have 2 upcoming webinars for our preventive health program. We are doing another newborn screening topic on cystic fibrosis on January 21st at noon. And then coming later in the year, we have a presentation on the Discover Diabetes program on April 17th at noon. And then I don't have it on this slide, but I did want to mention, because it's relevant to newborn screening, that we will be holding a focus group for questions about cystic fibrosis newborn screening with information that we will be giving to the state. So I will send information about joining that call in my follow-up email as well. And then Dr. Bowling, I don't know if you wanted to say anything about that, and then we can go into questions.
Yes, and so if you remember too, that's all of our PHP members. We're going to really lean on you next week at 12:15 on Wednesday. So be expecting a preparatory email from us with some of the questions. We're really looking forward to getting everybody's input on that cystic fibrosis topic. We're going to be hosting Dr. Caitlin Krivchenia from Nationwide on that call, and she's really looking for our information. I was going to actually, Anna, Rachel, and Brandon, I don't know if you saw my question in the box there too, about the finding that rhabdomyolysis can be a sign of milder not milder DMD, but milder expressions of the gene. If we have patients, like who obviously didn't have this screening done before, is a history of remote rhabdomyolysis an indication for doing more screening for DMD?
I will say that if you have patients who have rhabdomyolysis, especially recurrent episodes of rhabdomyolysis, they could absolutely benefit from a genetic evaluation for DMD and a lot of other things too. There's a handful of inborn errors of metabolism that can contribute to episodes of rhabdomyolysis.
I see patients here with that not infrequently.
Yeah, that as an indication alone, rhabdomyolysis would be a wonderful referral for a geneticist.
Okay, thank you. And that's the one case in particular is a female that I'm thinking of, and it was probably 20 years ago, 25 years ago. So I'm sure there's more that can be screened for at this point.
And I'll add that, especially as pediatricians, I think we're happy to get those kind of referrals, because as patients get older and they transition to adult medical care, females with rhabdomyolysis are unfortunately often their symptoms are not taken quite as seriously as the other male patients. So getting them in as a pediatric patient is typically better, not only to diagnose them earlier, but to diagnose them at all, because some patients with other inborn errors go undiagnosed until much later in life.
I will just add along the same lines that female carriers can develop the cardiomyopathy symptoms. And so that's another thing that identifying female carriers in families warrants them to get connected with cardiology, because many of them can develop cardiomyopathy. So that's something for them to be monitored for.
Thank you.
Okay.
Do you have a question in the chat that asks, are the gene therapy options for DMD available outside of clinical trials?
So Elevidys that is the one that's currently FDA approved and people are using it for people outside of trials right now.
Any other questions? Again, feel free to unmute or you can enter them in the chat as well.
This
If
was
not,
really exciting,
oh,
guys. Very interesting stuff. We really appreciate it.
Thank you for inviting us to share.
And as we emphasize, please just contact us with any other questions or, any other geneticist, neurologist specialized in DMD in the area.
so we did have a question come in. Are insurance providers covering the gene therapy options?
They should. It's a good question.
I don't think that we have a good answer for that.
And then with many of these expensive genetic therapies, there are options from the companies that produce the medications with assistance for families, financial assistance to help make it so that the children can get the treatment. So should not worry about financials as a barrier to getting the patients the treatment. The insurance companies are covering this, or the drug companies will help with assistance programs for the families.
All right. Well, I'll just mention again, I'll be sending a follow-up email with information about applying for CME. And then, oh, we have another question. Is the recommendation to wait until 2 weeks of age to repeat the testing?
Yes, no matter what the initial result was, unless it was totally normal, if it was inconclusive or elevated, regardless of what the infant's initial weight was, wait until after 2 weeks of age to repeat the newborn screen or to collect a total CK.
And then a
And if
follow-up.
they're under 2 kilograms, wait even longer, because there's also there's an age as well as a weight requirement to get a valid answer. So if they're still under 2 kilos at 2 weeks, you'll still get inconclusive. They
Yeah,
have to be above the 2 kilogram weight limit.
we have babies who are in the NICU who were not able to get a clean newborn screen until 4 months old.
There's just a follow-up question to the insurance, and you may not know the answer. If Medicaid is covering the cost.
I think they're going to be, I won't say forced into, but I think if it's a recommended treatment, I think they are supposed to help. But I don't know specifically for the different Ohio Medicaid plans.
All right. Well, we will end a little early. Again, I want to thank Drs. Mitchell, Dr. Hoff, and Dr. Van Coyley for a great presentation. And if you have any questions about the presentation, feel free to email me, and I will send you an answer. And I'll send up a I'll send a follow-up email tomorrow. Thank you, everyone.
Thank you.
Thank you.
Bye.